this video because you have been scheduled for an anterior cruciate ligament reconstruction. I am sure you have many questions about your procedure. Hopefully this video will answer most, if not all, of your questions. If you have further questions, I will be happy to answer them at your next follow-up. Please follow along with the presentation booklet that was provided. I will discuss the procedure and attendant risks. I will cover the postoperative care you will receive and give you an idea of what you should expect during your postoperative course. Let's get started. Anterior cruciate ligament tears are diagnosed with a good history and physical and confirmed by X-ray and on MRI. Anterior cruciate tears cause instability and a feeling that your knee is giving out. Meniscus tears result from the femur and tibia trapping the meniscus in between them during twisting motions. The ligament injuries and/or meniscal tears cause knee swelling and pain. Meniscal tears can also cause locking, which means that the knee is stuck and will not bend or straighten. Patients describe shaking or gently twisting the knee, feeling a pop or click, and having return of motion. The torn ACL can also cause loss of motion, usually extension. Cartilage damage is a difficult problem with only limited ability to treat. These are the main problems usually associated with anterior cruciate ligament tears. The ligaments responsible for controlling front to back motion of the femur and tibia are located centrally in the knee joint and are called the cruciate ligaments. When the anterior cruciate is torn, the knee becomes unstable, which can lead to more damage to the cartilage and meniscus, resulting in arthritis. Knee arthroscopy, also known as a knee scope, is an outpatient procedure done through 3 small incisions. Through the small incisions, I am able to insert a camera to directly see the structures of the knee joint. The camera is fixed inside a larger tube. Water flows around the camera inside the outer tube to fill up the knee joint. The fluid is held inside the capsule, resulting in increased pressure, which serves to decrease bleeding and to separate the knee structures for visualization. The first part of the knee scope is the diagnostic portion. During this part of the arthroscopy, the entire visible portion of the knee joint is inspected and then probed. The preoperative diagnosis is confirmed and other injuries can be identified. Usually, meniscal pathology is addressed before ACL reconstruction. Meniscal repair is preferable, but only applicable in younger patients with adequate blood supply to the injured tissue. The older we get, the less blood supply is present in the meniscal tissues. Therefore, more often than not, the meniscal tear is removed, leaving a stable meniscal remnant. The ACL reconstruction is then performed if needed. For ACL reconstruction, the torn ligament is being removed and replaced with new tissue called a graft. There are multiple tissue sources for the graft. An autograft comes from you, and an allograft comes from a cadaver. The allografts are taken from the organ donors who passed away for various reasons and are stored in tissue banks. Allografts are examined closely for any evidence of disease, making disease transmission extremely unlikely, occurring less than 1 in a million times. One autograft source is a segment of the patellar tendon with attached bone from the patella and tibia, called a bone patellar tendon bone graft. Another common autograft is a medial hamstring tendons. The allografts that I use are almost always soft tissue tendon grafts from large tendons in the leg and foot. The different grafts are fixed in different fashions. All grafts are passed through tunnels drilled in the femur and tibia in a specific position to act as the ACL. A bone patellar tendon bone graft is fixed in the tunnels using large absorbable screws. Soft tissue grafts are fixed with a combination of screws and metal buttons. Strong fixation techniques allow an accelerated rehab. Weight bearing can be immediate and range of motion unlimited. Other procedures such as meniscal repairs or cartilage treatments sometimes require modifications such as limitation in weight bearing or motion. Generalized cartilage damage due to arthritis is not readily treated. Isolated discrete cartilage injuries can sometimes be treated with techniques involving marrow stimulation known as microfracture. Another alternative in specific circumstances involves transplanting a good area of cartilage with its underlying bone into the area of damaged cartilage. These treatments alter the postoperative treatment in that you would not be able to bear weight for 4 to 6 weeks. Meniscus repair is done with suturing, reapproximating torn tissue and allowing it to heal. The healing rate for meniscal tears is around 80%, actually better in the setting of an ACL reconstruction. Meniscal tears which do not heal frequently require repeat arthroscopy. After meniscus repair, the range of motion and weight bearing will be limited for several weeks. After surgery, there is usually no restriction in motion or weight bearing. Initially, ice, compression, and crutch use is very important. You must keep the incisions clean and dry until the first follow-up appointment at 10 to 14 days. After the first follow-up, when sutures are removed, it is okay to shower without covering the incisions. Physical therapy should start within 3 to 5 days. You will wear a hinged post-op brace for 6 weeks after surgery. It is 3 months before any exam for stability is performed on the operative knee. Return to play is about 6 months depending on rehab progress, range of motion, and strength. The procedure is painful and requires a pre-op nerve block, which forestalls pain onset for about 18 to 24 hours, allowing the patient to get ahead of the pain. I urge patients to take at least a small amount of pain medication before the block wears off. The pain usually requires narcotic medications for the first 3 to 5 days. Thereafter, most patients are able to manage pain with ice, Tylenol, and/or nonsteroidal anti-inflammatory drugs, such as ibuprofen or Aleve. Use crutches for the first 3 to 5 days, but try to bear weight as tolerated. To avoid blood clots, ambulate or move around every 60 to 90 minutes during the waking hours. It is very important to closely follow the instructions given by myself and the therapist. Stick with the program and only progress when told to do so. The risks associated with ACL reconstruction are the same for any arthroscopic knee procedure: blood clot, bleeding, and infection. Particular to ACL reconstruction, specific risks include recurrent instability and graft rejection. These complications are very rare, but usually require further surgery and antibiotic treatment. The best way to treat complication is to avoid them. ACL surgery is very successful. Accompanying injuries can affect the improvement realized from ACL reconstruction. As mentioned, it is very important to follow instructions and stick with the program to avoid problems after ACL reconstruction. A hardworking, compliant patient with a positive attitude has the best chance of success. Successful surgery provides you a stable knee, allowing return to many of the activities that you love.